Hello, everyone. This is the second event in the Shops Plus End of Project series on accelerating private sector engagement. My name is Gina Holtz. I serve as the Health Financing Director for Shops Plus. I'm a Principal Associate with Apt Associates, and I will be today's moderator. Sustaining health outcomes through the Private Sector Plus project is USAID's flagship initiative in private sector health. Since 2015, the project has sought to catalyze public-private engagement to improve health outcomes. The first event in our series covered stewardship. You can find the recording of that event at the link that should show it up in the chat box. While there, you can register for our third event on health markets and a final event where we will reflect on the project work and what the future holds. Next. We're recording this event and we'll send a link to the recording to everybody next week. During today's event, everybody will be muted, but we do want to hear from you. Please use the chat function to send us comments and questions. We'll respond to questions as time permits during the latter part of our event today. If you'd like to adjust your audio connection, you can do so by clicking on the More Options button, which are the 3 blue dots. And if you're having any technical difficulties, please ask our host, Kayla Thompson, for support. Next. So today's webinar is about health financing. Specifically, we will explore the critical role that health financing plays in improving access to products and services in the private health sector. Next. This next hour will provide a forum for USAID and others to reflect on achievements, challenges, and opportunities to expand access to healthcare in the private sector that are linked to financing. We'll highlight Shops Plus experience from 3 countries where we've worked: Tanzania, Senegal, and the Dominican Republic. We'll share lessons learned on how to reduce financial barriers that clients face when they access services in the private sector, including for family planning, HIV, and other priority services. Next. Over the life of the project, Shops Plus has sought to harness the full potential of the private health sector, which includes diverse actors such as faith-based facilities, smaller private clinics, retail pharmacies, outlets, and tertiary care facilities. One thing to note is that many of them are solo or small group practitioners. The private sector is also an important source of care. It delivers approximately 50% of healthcare in sub-Saharan Africa, and that number rises to 80% or more in some Asian countries. For some clients, when they access services in the private sector, it's with financial hardship. Next. Private providers are diverse individuals too. They range from informal providers to formally trained professionals, doctors, nurses, pharmacists, midwives, and other health workers. The global health community concurs that it's critical to engage a country's total health system, including individuals like these who comprise the private health sector, to improve health outcomes and to achieve the Sustainable Development Goals. Next. When the project started in 2015, we recognized that financial barriers, out-of-pocket costs, as well as opportunity costs such as lost wages while seeking care, remain one of the most persistent reasons that people don't access healthcare when they need it or at all. And when they do, as I said, it can come with financial hardship. This is especially important in the private health sector, where out-of-pocket costs are typically higher. Therefore, a key component of our strategy concerns finding ways to enable people to obtain more affordable private sector products and services. This is a major lever to facilitate access and use by our target populations. Next. Our strategy drew on global experience with public financing, specifically funds that are mobilized through taxes. Public financing helps reduce financial barriers for people to access healthcare in both the public and the private sectors, and it's a cornerstone to advance toward UHC. For these reasons, we wanted to find ways for private providers to partner more extensively with publicly financed programs in partnerships that complement the government's public health system and that may fall under government-sponsored programs, such as an insurance or a voucher program that is purchasing services from public and private providers. Next. Partnering with private providers gives governments an option to buy the services that they would otherwise need to deliver themselves. Done right, they can be a win for the government, the private provider, and clients. Partnerships where government financing for health flows to the private sector help governments extend their capacity and their reach, and can allow them to relieve an overburdened public health system. They provide more points of access and choice, and at the same time, lower out-of-pocket spending at the time of care. Partnerships between publicly supported financing programs and private providers can also promote equity and quality of products and services the program is paying for. Next. So it's within this context that Shops Plus partnered with governments and private actors to facilitate access to publicly financed goods and services delivered in the private sector. Our discussion today is relevant for all health services and products, and it certainly applies to those that we deem to be most essential: primary care, as well as other targeted products and services in areas such as family planning, HIV/AIDS, maternal child health, TB, or malaria. Next. So as I mentioned, we'll share experience from 3 countries: Tanzania, Senegal, and the Dominican Republic. Our stories will highlight a common trajectory of initiatives that intersect health financing and private sector engagement and aim to improve access to priority health services. This arrow depicts a conceptual view of this trajectory. One important notion is that it conveys is that partnerships and the support that surrounds them to facilitate access to private health services will evolve and grow over time. Next. So not surprisingly, partnerships begin often with more basic arrangements that are informal and simple. They may focus on increasing access to commodities that are in short supply. So examples would be long-acting contraceptive methods or ARVs. They may also be coupled with other forms of capacity building. The experience you'll hear about in a few minutes from Tanzania on partnerships to provide government-subsidized commodities in the private sector will illustrate some of these basic arrangements. Next. Basic partnerships can form stepping stones to expand and to formalize agreements, as you'll hear in the case of Senegal, where Shops Plus supported a public-private partnership to increase the number of private providers contracting with government-subsidized health insurance schemes. At this stage, agreements can begin to target an expanded package of priority services, again in health areas like maternal child health, family planning, or TB, or more recently, immunizations that are supporting a country's response to the COVID-19 pandemic. They can take on different names across different settings. They may be called service level agreements in some places, or simply contracts. And the activities that support them will be referred to by the governments as outsourcing, or possibly contracting out, or contracting in when the private sector is hired to come into a public facility, or simply referred to as contracting. And their terms continue to evolve. They will become legally binding. They'll often reflect more terms, more conditions, and take on a longer-term perspective. Next. Next slide, please. So it's my pleasure now. Next slide, please. Yes, thank you. It's a pleasure for me to introduce 3 colleagues who have been leaders on the ground where Shops Plus has worked at points along this trajectory that we just saw. So our first panelist is Maureen Ogada Ndikana, our Chief of Party in Tanzania. Next, we'll hear from Dr. Isi Toure. Isu was our chief of party in for Shops Plus in Senegal until the program concluded last December. And our third panelist is Mina Halpern Lozada. Mina is the executive director of Clínica de Familia La Romana, a Shops Plus partner in the Dominican Republic that provides healthcare to vulnerable populations. Mina brings the crucial voice of a private provider to today's conversation. So welcome, Maureen, Isu, and Mina. Let's begin our conversation by having each of you share an overview of your work. We'll go to Tanzania first and start with you, Maureen.
Thank you, Gina. As previously introduced, I am Maureen Ogaden-Dekana, an accredited pharmacist with interest in leveraging private sector models to solve health market challenges. As a pharmacist and a professional working in the development health space, I have been on different ends of the spectrum of strategies that focus on facilitating partnerships for private sector inclusion in country health systems, including health financing. For the past 5 years, I have worked as the chief of party for the ABG-led Shops Plus project in Tanzania, and today I will share some of the foundational work we are doing to enable our growing pool of private providers to overcome barriers to accessing health services through their facilities. Next, please. I would like to start by sharing a few interesting highlights on the health financing and private sector spaces in Tanzania. By 2019, there were about 58 million Tanzanians, most of whom were uninsured. And at this point, about 23.9% of our country's health spending was out of pocket. Our health financing system it's highly fragmented. We finance healthcare through several programs, including insurance, but the dominant government-sponsored health insurance programs covers only about 25% of our population. The National Health Insurance Fund that serves formal sector households covers 9% of the country's population. A separate government program, the Improved Community Health Fund, popularly known as ICHF, covers the informal sector and low-income segments. ICHF covers approximately 16% of our country's population. To touch on the private sector, out of tens of thousands of private providers of diverse cadres, you will be surprised to know that just with drug shops, Tanzania has 14,000 outlets, and this is a growing number. The large and diverse nature of our private health sector presents an opportunity for increasing access to care through public purchasing of private health services. And this actually is in the vision, since a key part of our universal health coverage strategy is to consolidate the health insurance programs to a comprehensive health financing strategy that is focused on single national health insurance, with features including improved benefit packages and to further include private sector providers. However, we are only in the initial stages of this plan. Next slide, please. Our private health sector in Tanzania has surely come a long way since 1977, when private health services were banned in the country, only to be reinstalled back in 1993. As the private sector becomes more robust, today's challenges are different, in that even though Tanzania does have private providers, including even drug shops, participating in the two major government-sponsored health financing schemes, there are even more private providers waiting to be empaneled. So I would like to speak a little to the challenges that exist. There are two main reasons for the limited enrollment of private providers in government-funded insurance programs in Tanzania. One is that private providers face difficulty in accessing commodities and in accessing clinical capacity training that are prerequisites to getting the accreditation to offer key services such as HIV and family planning services. An example we can draw on is implants that are unavailable in the private sector, meaning that private providers in Tanzania can only get implants from the public sector supply chain. This limits participation and is often misconstrued as a lack of interest by private providers, and as a result, they are left out entirely from government-supported health services as well as from health financing opportunities. A different but related challenge is the preference amongst insurance programs to work with larger one-stop shop providers, and this results in the exclusion of many smaller private providers who are often embedded in underserved communities. We have also seen a resistance to work with private providers within certain proximities of public facilities. Next slide. I would like to bring your focus to the foundational work done by the project to overcome specific barriers to accessing commodities. Shops Plus linked over 1,500 private providers of various cadres to ministry-facilitated family planning and HIV clinical trainings. These trainings are a prerequisite to them accessing commodities through the public sector supply chain. So, equipped with clinical skills and commodities, these private providers were then accredited to introduce HIV services and to expand their family planning services delivery. An example is the commodity partnership with facility members of the Private Nurses and Midwives Association of Tanzania to increase provision of services using government-subsidized contraceptive implants and subsidized ARVs. Through these partnerships, public sector treatment sites in Tanzania are now able to refer stable clients to use nearby Primark facilities to pick up their ARVs. And on the other hand, clients who are able and are willing to pay for service fees are getting implants and other long-term family planning methods from Primark providers. This early and foundational work is seeing to it that private providers in Tanzania are taking up practices and making improvements in personnel and improvements in infrastructure, all of which are stepping stones towards larger, more structured contracts that will include more private providers in NHIF, as well as in other financing programs over time. Thank you, and over back to you, Gina.
Thank you very much, Maureen. Next, let's move to West Africa, to Senegal. Isu.
Dear Gina, participants, good morning, good afternoon. Thank you for this opportunity to share the Senegalese experience, engaging private providers to reduce financial barriers to access care. I'm Dr. Issa Touré, the Chief of Party for Shops Plus Senegal for 4 years. Our program ended in December 2020. I am a physician specialized in public health with more than 30 years experience in health system strengthening. I worked with USAID, WHO at country and regional level, and lastly, up to associate for Shops Plus. Slides. Let me share key information. Senegal is a West African country with about 60 million people. Senegal is among the lower income countries with nearly half of the citizens living in poverty. The government is committed to reach WISI, but in early stages. An important part of this commitment is to scale up enrollment in mutuals. Mutuals are community-based health insurance schemes that operate for the benefit of their members. Mutuals have operated in Senegal and other Francophone countries for a long time, but it is only recently in 2013 that the government has begun subsidizing premiums to enable more people to enroll. Slide, please. In Senegal, we face numerous challenges to reduce financial barriers for people to access to health services. Currently, most people, about 80%, have no health insurance. As a result, more than half of all spending for healthcare comes from people's pockets. Our public sector does not have enough providers, facilities, and products to care for everyone. Often people must seek care in the private sector to meet their health needs. And the community-based insurance schemes I mentioned, mutuals, struggle to attract and retain clients. They generally cover very few people. We have more than 2,700 private health facilities across the country that provide substantial amount of care, but so far, few of them hold contact with the mutual. They are also facing the same challenges that Maureen talked about. When clients access care from them, they paid out of pocket. Slide, please. In response to these challenges, our objectives were to increase financial protection and enable access to care in private sector, test an approach to convene public-private actors that would facilitate contacting between mutuals and private providers, co-develop sustainable partnership through contract for everyone. Slide. Let me share what we did. In supporting of the Senegalese strategy to scale up mutuals, we worked closely with representatives of the USC agencies and leaders of our National Alliance for the Health Private Sector called ASPS. We thought to reduce financial barriers to access healthcare by increasing the number of private providers contracting with health mutuals. We believe that contracting with more private providers at fair rates can enable mutuals to cover more people. This is an area where we have much more to learn over time and across different settings. We conducted a contracting pilot in 2 districts. Some key activities we undertook were sensitizing government and private sector stakeholders. We began at national level, then cascaded messages to local stakeholders. It was really valuable to have senior officials acting as champions. In each site, we worked with local counterparts to design and test our contracting approach. Probably the most important element of the pilot was to reach agreement on what fees the mutual would offer to private providers. ShopSupply also complements our contracting work by making the case to the USC agency to include family planning in its benefit package, which is now the case. Slide. The contracting pilot yielded more than 200 new contracts with private providers as of March 2020 and a lot of lessons. It is gratifying to know the government is using this experience to replicate the effort across the country. The pilot also dispelled the myth that private providers are not interested to engage in health financing programs such as health mutuals. They need to sustain their practices and want to care for members of their community. Contracting with private providers is possible, even when schemes are small and the USC is at an early stages. And in just 2 districts, the pilot demonstrates how local context can influence the approach and the outcomes. For example, the historical relationship of the private and public sector varies, and the number of and type of private providers and mutuals are not constant. The socioeconomic status of the community matters too. We observe throughout the pilot that dialogue at both national and local level with representatives from the government and the private sector is important to build the consensus and engage leaders to visibly support the rollout of the contracting. I hope you find it interesting and thank you for your kind attention.
Thank you very much, Isu, for sharing lessons learned from Senegal. Let's move further west now to the Caribbean and Dominican Republic. Mina, over to you.
Thank you, Gina. I'm Nina Halpern-Losada, the Executive Director of Clínica de Familia La Romana in the Dominican Republic. Next. The DR is a small country in the Caribbean with a population of 10.7 million. Here in the DR, a main vehicle for financing healthcare is through our national health insurance scheme called SENASA. SENASA was created to ensure that the most vulnerable Dominicans have access to health insurance. It currently covers about 40% of the population. In the DR, 63,000 people are living with HIV. In the past, donors like USAID have helped pay for HIV services delivered in the private sector at clinics like ours. And more recently, SENASA began to cover HIV services for its beneficiaries, although less than half of people living with HIV currently have SENASA. Next. Today, I would like to share the story of how our clinic, in partnership with Shops Plus, is adopting a new business model in which public financing from SENASA is a key pillar. A little more background about us. Clínica de Familia is a Dominican NGO serving vulnerable populations, including over 2,400 people living with HIV. This makes us the largest provider, public or private, of HIV services in the eastern region of the country. We provide over 150,000 services annually, ranging from clinical care to diagnostics to community outreach. I'll start with a short video that highlights our journey with Shops Plus. Let's watch.
La prevalencia de VIH en la República Dominicana es de un 0.8% de la población y es la segunda prevalencia más alta del Caribe después de Haití.
The services that Clínica de Familia provides to our clients are absolutely essential in their lives. A normal day at Clínica de Familia La Romana, we would have maybe 150 clients that would be coming in to get services. Without these services, many of them would not be receiving care and could die. They got to really know the clinic, what our needs are, what our weaknesses are. If it just had a one-time training, Shops Plus would never have learned all of those things about the clinic, nor would we have gained all of the knowledge that we have over the years. One of the biggest projects that we've had has been opening our dermatology center. The idea came out of the consulting work that Shops Plus did with us way back in 2018. The dermatology center is designed to generate revenue through the services that it's providing. That revenue will then help to cross-subsidize the services for people with HIV that we provide. Shops Plus support was absolutely key in us gaining a contract with SENASA, the government health insurance. A very large portion of our clients with HIV have the SENASA insurance. So we were providing services to them, often free of cost, while they had a private insurance that we could not charge. It has made a huge impact on our bottom line and the revenue generation that we are now doing. I really believe that all of the support that we've received from Shops Plus and all of the growth that we've had over the years of the partnership are going to serve us so well in the current environment. Now more than ever, we need to depend on ourselves to generate the revenue that we need to survive and continue to provide quality care.
As I alluded to in the video, Clínica de Familia is undergoing a transformation from relying on grants to becoming a financially self-sustaining enterprise that continues to deliver quality services to clients. In addition to generating income from new services like our dermatology center, financing from SENASA is a key component of this transformation. When Clínica de Familia partnered with Shops Plus in 2018, our goal was to develop and adopt a more sustainable business model. The project helped Clínica de Familia improve core business practices and service delivery while encouraging us to think and act more like a social enterprise. We focused on skills that we needed to improve operations, revenue generation, and operational efficiency of the clinic. Through training and mentoring, Shops Plus helped us understand that a self-sustaining enterprise must undertake a variety of interventions. Together, we created a business plan aimed at improving the financial outlook for the clinic. Accessing public financing through a contract with SENASA was one part of that plan. Until very recently, members of SENASA could only receive benefits if they sought care at public hospitals and health centers. In September 2019, I'm proud to say that Clínica de Familia became the first NGO to sign a contract with SENASA. This contract allows us to tap into a new stream of revenue from a public source. Contracting with SENASA is a critical step for us to ensure continuity of care and financial sustainability of the clinic in the absence of ongoing grants. Thank you so much.
Thank you very much, Maureen, Isu, and Mina, for sharing these experiences from Tanzania, Senegal, and the DR. I'd like to invite our panelists to turn on their videos. And I have a few questions that I'd like to begin with before we take questions that are coming in from our audience. So I would like to encourage you, if you do have questions, please submit them. I see that they're now beginning to come in, so we'll do our best to tackle those in just a few minutes. So let's start with Mina first. Clínica de Familia is larger than the typical midwife practice that Maureen described in Tanzania, where they've focused on procuring commodities and in anticipation of eventually contracting with the NHIF or other insurance programs. In the DR, what skills did your clinic need to acquire to partner with the SENASA program, and how did the clinic acquire them?
In terms of skills that we required, we had limited experience with business planning, so we worked with Shops Plus to develop the new business skills that I mentioned previously. Our plan included the implementation of new marketing techniques. Shops Plus staff mentored our marketing team over several months to begin using new marketing tools. We also took advantage of training to help us perform other activities to improve revenue generation, such as updating our fee schedule. Another way in which we honed important skills and gained experience is by contracting with private health insurers. Over the last 8 years, we've signed 7 such contracts. Importantly, our experience going through the accreditation process, submitting claims, and monitoring our payments from a third party helped us get our feet wet working with health insurers, really preparing us for a larger contract with SENASA. Indeed, the experience working with those private health insurers prepared us to manage the much more cumbersome administrative requirements that SENASA imposes on providers.
Great, thanks.
Allow me to make a quick comparison to what Mina just shared for the DR. In Tanzania, the private providers we work with have also benefited from training to develop certain business skills, including inventory management, profit and loss analysis, and they have also been recipients to coaching on business plan development and loan application processes. Introducing these trainings have increased private provider access to loans, and they are investing these loans in equipment needed to improve quality of their practice and to make infrastructural improvements that are needed to initiate as well as to expand services provision. And all of these improvements that the loans can afford these private sector providers are stepping stones towards meeting needed requirements to qualify for future health financing partnerships. Thank you.
Thank you. One point that I can draw from the remarks of both Mina and Maureen is that business skills are essential for private providers, as well as their counterparts, to form the partnerships to deliver sustained and quality private health services. Let's move to Senegal and go back to the efforts there to expand contracts between private providers and health mutuelles. Isu, a question. I'm curious to hear what surprised you most about the results of the contracting pilot and why?
Well, Gina, there were several outcomes from the pilot that surprised us that I would like to share. Mutuals value working with private sector to provide services that may not be available in the public sector, but they worry about the cost of purchasing services in the private sector that are also available in the public sector. We were surprised, however, to see the degree to which private providers were willing to accept payment rates from mutuals that might be less than they usually charge. In one district, private providers mentioned that they are used to adjust their fees based on the ability of their client to pay. Another surprise was that mutuals might in some cases pay less for a services rendered by a private provider than a public provider. This is because the cost sharing provision between mutuals and their members differ. By that I mean the mutuals pay a lower share, 50% of the fee for a service at private facilities than at public facilities, which it is 80%. In this case, the client pay more when they use the private facilities. Over to you, Gina.
Thanks, Isu, for illustrating that private providers are not a monolith, and I'm encouraged to hear that many are eager to partner with publicly supported programs, and that they are seeking terms that will be sustainable for them, but also for the program and be beneficial for clients. Maureen, I'd like to come back to you. Based on the experience you have around partnerships to facilitate access to commodities, what insight have you gained more generally on establishing and nurturing partnerships to access financing programs in Tanzania?
Gina, a main insight that I can share from our experience in Tanzania is related to where the starting point is with these partnerships. And more importantly, the need to invest resources and to invest time in foundational steps that focus on more basic agreements or more basic partnerships, like the one I previously highlighted for commodities. These are usually more informal, they are smaller, and the procedures and the capacity needed to put them in place are less developed. These foundational partnerships can be messy. We have found them to be imperfect, but quite a useful learning laboratory and a way to set up practices to meaningfully engage the private sector. So I would say for any else system, it is important to start where you are and then go from there. Thank you.
Yes, Maureen, your insight about investing in partnerships as well as foundational skills and seeing your experience as an active learning laboratory, I think supports the idea that public-private partnerships linked to health financing develop over time, and they're worth pursuing, but typically in a stepwise fashion. So follow-up maybe to that for you, Maureen, would be as you reflect on those lessons learned with private providers to expand access to commodities and services, and you think about, from their point of view, how to eventually contract with the NHIF or other schemes. Tell us what you see as the next frontier for learning.
It would be interesting for me to take on the voice of a provider as I answer this question. An important avenue for learning would be to explore which mechanisms will aid publicly funded programs like our very own NHIF and ICHF to establish fair and justified payment rates for private providers. One consistent outcry from our participating private providers is that these payment rates and methods impact the equity as well as the quality of services they provide. A lot hangs in this balance as we in Tanzania continue on our trajectory. By this, I mean that payment approaches are critical to expand and sustain these health financing partnerships that are just beginning to form. So examining how to structure them is an excellent opportunity to really think through the incentives that we can infuse into these partnerships. Now, on the other hand, another area worth learning more about is the broader role and contribution of private sector in moving towards universal health coverage. For countries such as Tanzania, this might mean a greater role for the private sector in increasing access and increasing utilization of health services and health commodities amongst certain target population groups, or even their role in increasing choice. It might be, to collaborate with other stakeholders in examining policies that facilitate private sector participation in health financing programs. And one final way would be for them to participate in disseminating health information and participate in health promotion.
Thank you. Thank you, Maureen. Maybe same question over to Isu in Senegal. Please tell us what you see as the next frontier for learning as you reflect on the experience of the contracting pilot to expand contracts with mutuelles and private providers.
Well, Gina, I would like to build on my last comment about financial terms of the contract that resulted from the pilot in Senegal. And also, let the participant know that the Director General of the agencies decided to expand the experience in the whole country. So something ongoing. So we need to learn more about the effect of the contract on all stakeholders, the mutuals, the providers and clients, and how to optimize them. So there are many questions we would like to ask to unpack this. For example, how do these new contracts affect client retention? Claim costs. Do the contracts pay private providers sufficiently to sustain their operation without sacrificing quality? What are the administrative costs? And how do we manage them? A longer-term question will be, how does greater access to private providers affect population health? And I would like to also respond to one question from the audience. We use to work with the agencies to help them to set lists of indicators using the same database that they have to monitor in a quarterly basis what is ongoing. And this will help to, in fact, respond to this question. Thank you.
Thank you, Isu. I think we can squeeze in one more question before we turn to our audience questions. Thank you for submitting them. We can see that they're coming in. So Mina, what has Clínica de Familia learned about how to manage its contract with SENASA? How have contracts that you hold with insurance schemes affected your clinic's operations?
Well, we've learned that working with third-party purchasers like SENASA or private health insurance schemes is really putting our business skills to the test, incentivizing us to operate more like a business. For example, we have streamlined our registration process to reduce bottlenecks for our clients and our staff when we verified the eligibility of the client and determined what proportion of their services are covered by insurance. Hiring 2 additional staff for insurance authorizations has helped us speed up the authorization process, but it also increases our expenses. On the back end, it's critical for our financial viability that we submit accurate, timely claims and track payments. These steps become more complicated as we add more contracts with health insurers, as the requirements for each insurer are slightly different. Not surprisingly, SENASA wins the prize for being the most bureaucratic of all the insurance programs that we work with.
Thanks for the reminder, Mina, that business performance is really critical to sustain operations, especially when working with third-party payers like SENASA, and they complement clinical excellence. Just to follow up, one final thing on my mind here is that I heard you mention that historically, even though most people living with HIV in the DR are eligible to enroll in SENASA, only about half of them actually do. Could you shed some light? Why is that? And what can be done to enroll them in the scheme?
Yeah, that's right. As we know, insurance companies require people to be enrolled in order to access benefits, and it's more challenging to reach certain groups, like people living with HIV, who are more likely to be lower income, and lack a national identification card. Last year, the Dominican government ramped up its campaign to enroll more people in SENASA, but unfortunately, undocumented residents are still not eligible. At the clinic, about 30% of our clients living with HIV currently are covered by SENASA. Our social work department is working to identify those who are eligible but haven't yet enrolled so we can get them covered too. Having more of our clients covered or enrolled in SENASA is good both for our clients, providing them obviously with the health coverage that they need, and Clínica de Familia providing us with much needed revenue.
Thank you, Mina. Let's turn to some questions that have come in from our audience. I see we have about 14 minutes remaining in today's webinar. So maybe just to take a question that has come in for Isu. What are plans to extend the contracts from the pilot? Does the government intend to scale up the pilot elsewhere in Senegal? Isu?
Thank you, Gina. I already answered this question when I was responding to your question. Yes, it was really one of the big achievements from this experience. And even before we stopped our experience in one of the areas, like Kaulak, the mutuals decided to extend in all the region, because in each region of the three, we selected only one department, and they decided already to expand it in all the region. And the Director General of the agencies also decided to put it in their national strategies, and this is the case at all national level. One of the big really decision that was made by the Director General was to scale up this experience in countrywide.
Right. So it sounds like it's going to spread beyond the 3 districts to other parts of Senegal.
Yes, sure. Yes.
Yes. Thank you. I see we have a number of questions from the audience around payment, and it's always that elephant in the room. Some questions around how do the contracts work once they're effective? Are the insurance schemes paying the providers on time? What do the providers do if they don't get paid on time? So I think those are some of the thoughts that are bubbling up in terms of how these agreements function in terms of cash flow and payment. So that's a general question around payments and timeliness of payments. I would invite any of our panelists to comment. And I will also maybe mention one specific question while you're thinking about that generally, that is for Maureen in Tanzania. This is around a question for just some clarification about how the contraceptive implants are distributed and shared from the government to the private providers. For example, is there a limit on what the private providers can charge for those implants? And are there certain brands or types of implants that are available and not others? So I think just a brief clarification around how the implants are getting into the hands of private providers and how those work. Maureen, is that something that you can maybe begin with? know it
Yes,
well.
Gina. Yes, Gina. Thank you for those questions. I'll probably begin by addressing, the first general question, because it definitely speaks to some of the concerns that are raised by our participating private providers in Tanzania. Claims submission processes, the time it takes for payments, and like I mentioned earlier, the payment structures, right? Are they justifiable and are they fair? So, because of the lag in time, or the lapse in time that it sometimes takes for private providers to receive their reimbursements, Shops Plus has, in addition to some of the work I've mentioned that we're doing, we have also worked with our, local financing institutions, local private financing institutions such as banks and microfinance institutions as well, to develop some innovating financing to act as buffers, as buffers for cash flow for private providers as they wait for reimbursements from NHIF. So that has been something innovative that we're doing in that space. In terms of implants, Gina, and the supply from public to private sector, I mentioned this in my presentation. There are prerequisites to accessing these commodities, training being one of them. And it's apart from in-class training, this is also coupled with hands-on coaching for clinical skills for the private providers to actually insert the implants. One of the I would say the modules that we have included in our business training when we do it is ordering of commodities, reporting of commodities, right? As well as building relationships between private providers and their local government pharmacists to enable that easy flow, or to make the flow of commodities more efficient. So private providers order from their local pharmacists, they get the commodities, and based on their consumption, they report back to their, to their local pharmacists every month, saying what they have used, as well as making a reorder. Thank you, Gina.
Great. So let's go back to the general question about payments. And maybe let's start with Mina, because you have perhaps the most experience working with insurance programs in SENASA. So could you tell us about how the clinic is, what your experience is and how you manage that?
For sure. It's a great question. And it's actually very complicated with so many different insurance companies that we're working with. They all have different deadlines for when we submit our claims, and then their auditing process, and then when we get payment. We have found, though, that most pay within the time of us submitting a claim. Usually within a month to 6 weeks, we will get payment. For the most part, they're pretty regular. So we now know when payments are going to be coming in. For the most part, we know how much is going to be coming in. And so we can plan accordingly in terms of managing our cash flow. SENASA, their process is very labor intensive. They do a lot of auditing. They come every month. The person actually comes, spends an entire day here auditing all of the claims from the previous month. It's pretty intensive, but they are very detail oriented. So we've had to make lots of changes in terms of the way the doctors fill out the forms, the way they're submitted. If one thing's out of place or one box isn't ticked, then they will reject that claim. It's pretty intense. But we've been learning, over the last year or so, how to manage that. I'd say that our bigger problem, now that we've kind of got that under control, has to do with reimbursements. We have much better reimbursement from the private health insurers than from SENASA. They have very low reimbursement rates. So we're actually currently in the process of negotiating with them a new fee schedule, or how they'll reimburse us, which we're hopeful will be successful. It's not actually all that sustainable, our current contract. So we're working on that, one step at a time.
Indeed. And I think I see a comment, this is from William Wells, around what he's referring to as the tension between payment methods and also rates, as you're bringing up, Mina. And I think the work is never done. You mentioned that you're renegotiating and looking to make adjustments to those fees. it is something that needs, it's like a garden, in fact, that's how I think of it, needs constant sort of replanting and tending. But there are, I think it follows that arc that we discussed in terms of starting with simple to administer, simple to understand payments, but over time, fine-tuning those to perhaps incentivize the provision of priority services and to encourage greater efficiency. Any other comments around payment? Quick ones. We have just a couple of minutes before we wrap up.
Yes,
So,
I just
short
would
one,
like
please.
to if you allows me, Gina.
Yes, please.
We have an experience that I would like also to share. It is related to mechanisms, deposit mechanisms that reduce the risk of delayed of non-payment from mutual to private providers. And in this case, in the event of a delayed or mispayment, private providers can draw from the deposit according to the provision agreed to by all by all parties. And over time, other mutual build trust among private providers by demonstrating timely, reliable payment, demand for a deposit should diminish. So this is one example that I can share. It is not the case in the old department, as it was in 1 and 2 department, but the other it was not the case. Yeah. And organize in a quarterly basis a meeting to allow all parties to sit together and identify if there is any problem, how to solve those problems.
So thank you, Isu. We have just a few minutes left. I would like to ask each panelist to give a very concise last piece of advice to our colleagues today who are listening. How would you, for those who are increasing access to private sector products and services through financing mechanisms, what advice would you leave them with today? Let's go to Maureen first. Any order is okay.
Thank you. So for countries that are just starting out, like Tanzania, my advice is that aside from our focus on enrollment with insurance programs, it is important to focus on other foundational interventions to help to reduce barriers to accessing private healthcare. So, like I mentioned, in Tanzania, training in business skills has been very useful. Stronger business skills for private providers serves as prerequisites for future financing partnerships with NHIF as well as ICHF. So for example, private providers with better business skills are more prepared to invest in equipment, they're prepared to invest in people, as well as in infrastructure needed to improve the quality and the breadth of their practice. We also found it is important to assist them in other foundational interventions, such as reporting to the national HMIS system and participating in local government-led supportive and regulatory supervision. Thank you.
Thank you. Isu, a short piece of advice from you.
Based on our experience, my advice would be to support public-private dialogue for partnership, such as contracting between private providers and health financing program. Relationship matter. Dialogue helps us to fill the information gaps about both the private and the public sector. Explain the strategic vision of the government and to break down barriers and prejudices and misperception that public and private actors can work together. And finally, establishing contact between mutuals and private providers is time and labor intensive that require for everyone who decide to work in this area to be patient and perseverant. Thank you.
Thank you, Isu. Final short piece of advice from the Dominican Republic, Mina.
I would like to encourage peers to pursue their own transformations to more sustainable business models. In addition to building our business skills, partnerships with public financing programs like Clínica de Familia's partnership with SENASA are core elements to change. We must adopt a new paradigm of self-reliance and infuse a business approach across all that we do, but always with an eye toward delivering accessible, high quality, and sustainable care to our clients. Thanks.
Thanks very much. Next slide, please. So I think I see that we have unfortunately run out of time, but these were a few final takeaways from my side around the opportunities to partner with financing programs to extend access to public or to private products and services, that these partnerships develop over time, and that some of the key ingredients to infuse along the way, and we need to think about where we are in that trajectory, includes building skills, as we've heard about, and dialogue. I want to end our webinar today with the recommendation that I heard and I take away that Maureen mentioned, and I think we can all apply in the work that we do, which is start where you are and move on from there. So with that, I would like to thank our panelists, Maureen, Isu, and Mina, very much for today's discussion. And thank you to everybody who joined. Wish you a pleasant day or evening. Goodbye.